Hello. How is everybody today? All right, so the title of this topic is Blockchain and Revenue Cycle Management. Joining me today, we have Scott Law, who's Executive Vice President of Corporate Strategy for Zotec Partners, Jim Sohr, Chairman of Powered Health, Ray Herschman, Vice President of Accountable Care Strategy for Cerner, and Kyle Culver, who's the Solutions Architect with Humana. Please join me in welcoming these guys.
Okay.
I'll go right next to you.
Okay, cool.
So before we get started, we thought we'd level set with everybody real quick. When we say revenue cycle, who in here has actually had an experience in the revenue cycle, working in it? I see a few hands. All right, so for those of you who have not, we'll define that conversation because it gets pretty broad. Basically, it's the non-clinical and the non-administrative functions in healthcare, or you can think of it as the monetization of healthcare claims. So in layman's terms, it's the coding, the billing, the collections of receivables. And these guys know something about that, whether from the payer perspective or the vendor perspective or even health information management systems perspective. So that being said, I thought what we would do is we would start with a quick, what's blockchain mean to you kind of conversation. So Scott, will you take that away?
What does blockchain mean to me?
Yeah. How does it impact your business?
So I think right now, I would say it doesn't impact our business today, but we're here and joining conferences like this to try to figure out how it will impact the business, whether it's on the claims side, the provider credentialing side, or where exactly it'll fit in.
Fantastic. Ray?
Nascent, early learning right now. I think the thing I think we're all looking for is when is there enough critical mass and some meaningful kind of proof of concept of what's possible. And I think, the herd will follow, but I think we're at that early stage.
I'd say we're early and very early, but it's a trustless network, which is the perfect solution for a completely trustless environment.
Well, very well said. Yeah.
I think, with it being so emerging, everybody's kind of in the same boat with that, trying to learn, trying to understand how it can impact the different revenue streams that they have or open up potential new revenue streams down the road.
All right. So from an underlying technology perspective, let's kind of unpack that a little bit. And this is going to be an interactive discussion. So you guys in the back, don't be like Baptists. You can move to the front. Come on.
Yeah.
No?
No.
All right. From the underlying technology perspective, talk a little bit about smart contracts. How do you guys see that impacting? I know everybody on this panel certainly paid their dues in the revenue cycle in one way or another. So how do smart contracts impact that business?
Well, I think, being able to codify, some of these relationships, so going from that legal to, the programmatic language, and that being something that's transparent. When we talk about, blockchain being something that has trust and it's secure, and it's really a lot to do with that transparency and the fact that you can have, this logic now that is seen by all, or at least more transparent, depending, I guess, on the use case. And so that smart contract really carrying that logic. So it's not just that we're sharing data, but we're also sharing, how the decisions will be made around that data.
Yeah, I'll add that, maybe 90% of all claims sort of go through the system without too much headache, but that last 10% cause a tremendous amount of problems. So medical billing audits, duplicate payments, coordination of benefits issues. Smart contract can start to address some of those and really remove the friction from the process going forward.
Yeah, I think also on the smart contract part, I don't know how many people here have actually had to configure benefit codes on the payer side, but I did an immersion a long time ago for about 6 months just learning how to code these things. And the concept of kind of a hat code, who's wearing the liability at which time over the course of a benefit and a reimbursement cycle is really kind of messy. There's a lot of handoffs. And so I think smart contracts will also be able to contemplate who's responsible for what part of the bill over time is going to be, essential, right? It's not a buy and a sell. There's, 3 or 4 people involved in the payment, and there's a lot of, on the provider side, you would think it's a single source, but there's a lot of different pieces feeding that as well. You layer on top of that the concept of bundle payment where it's vertical and it adds complexity. So I think that a smart contract is going to be able to know, that hat code, whose purse at what time are you tapping?
Yeah, and I think just the last part on that would be, a big part of our spend on the provider side is doing contract variance. And and that's what providers care a ton about, especially the bigger, more sophisticated providers who are contracting with various different entities on the payer side. And a smart contract, in theory, could solve that, and you don't have to have you could do that in real time versus, a 30, 60-day follow-up on, is this contract according to how I structured it with XYZ payer.
So guys, take that into an implementation discussion for a minute. How many providers are in the room before I make this extremely inflammatory comment?
0.
All right, 0, good. Milt, do not report this. So there's an old quip in healthcare that the healthcare on the business office side tends to lag 20 years behind normal business. I think that's being overly kind, having been in a lot of business offices. So as we talk about literally leading edge, bleeding edge technology, how do you implement that? And Kyle, if you can take that from the payer's perspective, because I've been in a wealth of payer back offices too. You're talking about legacy systems that are extremely intertwined. So what's the opportunity to drive that efficiency? And as you guys unpack that, also think about how do you take that from theory to reality in a world where you've got a lot of fringe players who will become disintermediated. What's the opportunity here?
Well, I think there was an earlier talk with the Aetna CMO when he was talking about just the waste in the system. We look at billing and insurance-related admin costs being over $300 billion. There's a huge opportunity there, and even if we don't get that to 0, being able to kind of attack that. And then from an implementation perspective, looking at, well, how do we make progress, right? How can we run things in parallel? We know that we're not going to be able to just throw a switch and then one day it's all on this new system. So how do we run things and take progress and make progress? And then getting back to just the incentives. And so when we look at this system, how do you incentivize people to adopt it? There's a reason that there's, fax machine is the primary communication in provider offices, and it's not because there's not better tech. And so we need to understand how to really incentivize and why someone is going to adopt across the different stakeholders. And I think, tying that back to Bitcoin, that's what it did really well, and understanding here are the different actors and here's how they work and how this system can be autonomous. And so I think looking at our solutions and saying, hey, within this space, who are the stakeholders and what are their incentives to participate?
So as you talk about incentives, the comment was made earlier today that sometimes free isn't a big enough incentive for a provider. How do you view that monetary movement?
I think you need to be able to prove it. One, I think saying something but showing someone is different. And I think being able to also say, this is what your cost is. So if you have this admin cost, that's X, and you can show, hey, I can reduce that at a transactional level, or I can get you data faster. So what are those ancillary benefits that may be there? And I know you have experience with, being able to look at, accounts receivable and some of that stuff and understand, hey, now you have a clearer picture of what your financials are. So I think it's a big story, but trying to make that consumable by the provider, and not just the big systems, but also, a lot of the smaller shops.
I think you get a provider to buy in by solving 2 of their biggest goals. One is to reduce the number of days in AR, right, and also reduce denials. So you can do that, and I think the way you implement this, it's got to be a really specific, defined, incremental approach. Start with something that's going to happen every time, like an authorization. A lot of providers do their job, they get an authorization for services, it's subsequently denied, and it's you have to start chasing the money, and it's huge burden. But think of a small blockchain application. Just a patient gets registered, the authorization is automatically kicked off. The payer gives that authorization, and it's locked in a blockchain. The payer can't ever say that we never got it, but just small things like that start to move the process along.
Yeah,
Right.
and I think that's that blockchain reaction kind of concept. It'll start spooling automatically different jobs that currently have really, latency along every step. So, one part of it is So who wins and loses? I think there's a positive-sum game if you say, the faster it goes, the better the system will be. On the other hand, one side's receivables, another side's payable. They're the analog of each other. They both have balance sheet risk, providers, receivable risk, payers, payable risk. Those are the two things auditors audit. You go and audit an insurance company, it's your IBNR, right? And you audit the receivables and say how much of this is really going to be paid to you. And the problem is when you go to like zero latency is that the people that have the payable, they're getting cash flow. They make money off of the float. That goes away. Over on the provider side, they're currently the bank. They've got receivable risk that they didn't necessarily volunteer for. It's how the benefits were written and how the reimbursement contract was, and all of a sudden they become the bank. They're holding the receivable risk. And so I think that as you pull both of those sides in, you could more appropriately move the receivable risk off of potentially the provider and put it back to whoever the payors are, whether it's the consumer, the third-party payer, the reinsurer. And that we're all paying for that friction. So sure. I think that's the part that I think we could get close to is we just shrink the time frame. It's going to change a lot of people's jobs, so that scares the heck out of people. But I think it'll start addressing some of what CFOs will say, okay, that's demonstrable, quantifiable value. I can put a number on that as opposed to kind of,
I think that
soft valuable.
I think the payable risk you talk about can be easily offset by a reduction in the administrative burden.
Totally. Or better pricing. There's a lot of ways you get benefit out of it, but it's the trade-off is you are giving up the cash flow, and that's that pays some bills, so it changes it.
But I mean, and then there's the other. I think first of all, I think Jim hit the nail on the head when you think about from a provider perspective. It's basically like what you just described is basically putting a read receipt on an email, right? They actually did read it, they did receive it, I got it back. Like I shouldn't have to go chasing my tail trying to prove to you that this is I did what I did. And I think that on the provider side, that's where you have a lot of opportunity to actually gain some ground, and a provider can say, oh, I can actually getting value from this blockchain thing. Mm-hmm. This is really cool. And then the last part on the payer side is, with high deductible plans, are you guys eating really that much float on a payer side? On a payment perspective, like a lot of that's coming out of the pocket nowadays. So I think that potentially makes it more ripe for this kind of innovations than historically when you had to actually hold a lot of that float on the payer side.
But if you think about how much information is continuously regurgitated,
exactly.
Continual requests for medical records, why not request it through a blockchain? Everybody knows it's been requested, it's been locked into it, but also have the medical record actually sent with not stored in the blockchain, but with a pointer in the blockchain to an outside data source. Now it's there. Everybody knows it's there. The record's immutable. And that's, again, how you make incremental progress.
Well, I think the patient experience and provider experience of being equipped to drive the conversation around cost share, and so I think there's some complexity around that now where that's programmatically accessible, as well as, the different accumulations for that plan. Now someone can have a very focused conversation in a short amount of time on this is what this is going to cost, and something that's really tougher to do at this point in time.
So let me ask you, though, could that sit in a patient record, all that information?
I think that they're linked, but I think they're different things that have very different, potentially technical implementations. So you end up with more of a financial thing and what needs to happen in the transaction times and the amount of data that's needed to be stored. And I know you were talking about the pointer. It could link to where that data is, and so I do think there's some overlay, but I could definitely see them playing out at different speeds.
So with regards to the speeds, what leads here? Is it the need for clinical information to be shared in kind of an immutable, we were talking on the phone in this prep called the golden record, if you will, or is it the financial side, or is it symbiotic?
I think there's a lot of ifs and assumptions.
It's a $64,000 question. Right?
Made there, though. But I think your financial, you have a lot to lean on with FinTech. And so doing a pure financial transaction, you have a bigger body of work, as well as looking at the EHR, the different regulations around PHI and PII information. I think that's going to take a lot more learning into, and a lot more, working with regulators and those type of things to make that work, even though that's probably the highest value use case. And I think you can learn into that space, learning more about like public data and what does it look like as an industry to have competitors that collaborate together. Like, what does that look like? How would that work? And I think once you start to solve for those problems, I believe the technology part won't be the hard part.
So that's financial and...
Well, so the financial, I think it'll go, with your public data and understanding how to play there, and then your financial, and then potentially the
clinical.
The clinical.
Jim, thoughts?
I still think it's at some point in time the patient's going to end up being at the center of it. It's the payers and providers, both in companies I've worked with in the past. We all believe that the patient's record is our asset to some extent. And you think about the challenges in people receiving care, redundant lab tests, all those things are a burden to the system. And to the extent that they can be attached to a patient record that is shared and, common view, everybody sees it, it changes, but the history doesn't change.
Right.
Go ahead and put the copay and deductible information in there, put their lifetime balances in there. So now the hospital can make sure that they collect and bill properly. But at the same time, this also impacts the employers, because many employers, whether may not be fully insured, they're self-insured. Every time you move a payer, move from administrator to administrator, your health record stays, which really screws up the market for people, because now, instead of having a clear medical history that may demonstrate the general health or wellness of your employee base, you've got to start all over. And that's primarily so the administrator can keep that business, make it increasing the shifting cost, but it's a burden on the system. And all these things incrementally are going to have some ultimately large impact on the cost of healthcare.
What about you guys? Any hard bets, financial, clinical, as to which leads?
Yeah, so it's a chicken and egg, right? I'm going with chicken. So I think that people don't really change until they start getting scared. They get chicken, and I think reimbursement kind of, I think it's sight of the gallows sharpens the mind. I think as soon as people get changed how they're getting paid, they'll figure it out. I think we got a forcing function of affordability that just is driving this. Cool technology for technology's sake, doesn't necessarily drive kind of wholesale change. I think we've got an affordability issue that's driving payment reform that will then get people to move. I think the other issue you brought up of that churn, that ambient churn, is I don't know how much folks have kind of really looked at this, but if you're looking at the disease management business or continuity of care, there's just a lot of concepts. And when you look at the amount of churn of people changing employers, employer changing carriers, there is, and then providers kind of acquiring and then dissolving and reforming, the amount of ambient churn is way higher than people understand. And that too kind of keeps breaking the logical kind of longitudinal aspect of a record, and so blockchain could address that inherent churn. The churn's not going away, so we got to figure out how to string stuff together, and we're all paying for that too. So that's a big get. I think that's a huge point.
Yeah, I think just piggybacking on from Ray, where you could just as kind of brainstorming see it at the beginning is like a Medicare Advantage plan, right? That's like a Culver or something like that, where they own the whole tech stack. So the answer to your question is the clinical or financial. In that case, it's both, because I am at risk and I also want to make sure that I can maintain this longitudinal record throughout time. And so I think that, and you have a lot less churn because it's in Medicare, and in theory, you can retain your population for a lot longer. So you could see it happening there, and you kind of get around some of these issues that we've been talking about.
Fantastic. All right, audience participation, show of hands. Who do you think leads? Financial? Any hard answers there? I see a couple of hands out here. Money, what's the question? All right, what about clinical? Anybody going to bet on clinical leading blockchain coming into healthcare? I don't see any hands, and these lights are not that bright. All right. One. All right, we got one. Fantastic. All right, so how do we implement this? What drives it? Is it payer-driven? Is it a Medicare Advantage plan like Clover, or is it provider-driven? Any thoughts?
I mean,
ACO driven?
I'll drop in real quick. I mean, like from a revenue cycle management perspective on our business, like I don't think we are going to drive it, right? Because we're going to need a payer or a capitated plan or some kind of contracting entity that we're with saying, we're moving to the blockchain. Here's how you do it, and then we're going to be reactive in that because we also have our entire rest of our client base that we're going to have to build the regular way, if you will. So, I mean, I don't think an entity like that drives it. I mean, that's my thoughts on it.
Yeah, it seems like it's got to be a two-party kind of, there's got to be a big enough payer and a big enough provider that say we're going to step into this together, and I think that provider has to say that I'm going to do it with a payer and figure it out, but then the way I'm going to do business with everybody else is going to be consistent with that model, and it'll kind of drive. Otherwise, it'll be a nice, as opposed to a prototype that you take to scale, it's a pilot. It goes on the bookshelf, people learn stuff, and it never goes to scale. So I think that as folks get more comfortable with it, and they've actually been able to prove out that there is incremental value along the way to the end state that people are working towards, then I think you could get a tipping point. And it doesn't have to be massive. I think it just has to be enough. Most markets tip on 3 or 4% acceptance. It doesn't have to be 90% acceptance to get the market to tip. So I think we just have to get enough, experience where people kind of trust that it's credible. They could bank on it. They could score it and budget for it and invest in it. Then I think it will tip.
And it doesn't have to be national either.
Right.
It could be very local. Right?
Yeah, absolutely.
I think that's how it works. And I think you're right. You're going to need two people to partner. But just sitting here today, you've seen so many companies that have a little slice of a solution. And I would assume that maybe there's some way to build a broader consortium and then bring the payers and providers. I'm not sure people are going to trust a pure payer or provider solution to do this.
Right.
You're going to need a community.
So is it somebody like a Change Healthcare? I mean, not to plug the plug, but...
That's interesting. Part of the reason you have blockchain is to disintermediate people.
Right. So who loses in this?
And he gave a great talk today. I thought he hit a lot of really salient points. But part of blockchain is some people would argue they need to change.
Can we get a rim shot?
I hate I said that.
Right.
Kyle,
Well, we
thoughts?
see, like with Swift in FinTech, so they said, hey, cross-border payments, Swift is going away, it's going to be disintermediated. And it didn't, it just built a blockchain and then said, hey, this is how we could do it more efficiently. And so I think you're going to see some of those reactions as well with some of the incumbents. Morgan Stanley put out some research talking about the need for incumbents in a solution for it to be successful. And so I think, what everybody's saying with, hey, a couple big people getting together and saying, hey, we're going to do this and this is how we're going to do it. Now there may be competition, right? There may be different, I think that's what we're seeing with R3 breaking up and the financial side, and then, competition for different blockchain implementations. So I could see that same way, but I think it'll be big players, at least getting to that tipping point.
So in thinking about moving to that tipping point, you mentioned SWIFT and monetary movement. Granted, that's cross borders and not what we're talking about here for U.S. healthcare, but talking about blockchain, little b, not big one. But do we ever get to a world where we all have Coinbase wallets or whatever, not to plug them, but patients paying copays and deductibles with digital currency? You guys think that ever happens?
Well, I think there are two very different questions. I think you could see a world where people are, who knows what happens, but people could be paying with digital currencies and blockchain is not implemented at all in healthcare, if that makes sense. You could see, today already you have websites, all kinds of things that take Bitcoin. So,
Right.
I think that could happen well before any industrial implementation of any kind of claims adjudication thing in the blockchain happens. So that's my thoughts. But.
Yeah. I don't know if it necessarily has to use that form of currency to take advantage of the capabilities of blockchain. It may. but Venmo works good too.
Sure.
As long as at the point of care you know what your real liability is as opposed to estimated liability, right? And that real liability is predictable when you have a copay, but as soon as it's a deductible and coinsurance and a formula, you're going the other way. So I think that the other point of kind of, getting things to move, it's possible that we are trying to solve a specific problem, like master provider data, and it's that the derivative value in another area is what really gets it going. That's why that spillover effect is why we all that's why I'm saying let's just try stuff,
Yeah.
We might end up with something that actually works really good on the clinical side and doesn't apply necessarily as quickly as we like on the financial side, but it's been enabled by our trying to make this stuff work. And I could see that being the case, because on the clinical side, there's a profile of a person, and it's complicated. You have a lot of different clinical attributes that determine my relative risk versus your relative risk, and so it could be that it improves, the continuity of care as you change carriers.
Yeah.
Right? It has nothing to do with payment. It's the quality of care, because you could string the stuff together.
That's right.
I think everybody could vote for that. That's a good thing,
Sure.
right? So I'm kind of optimistic that even if we don't achieve that specific milestone we thought we were getting, that we're going to learn enough that we'll find alternative applications in short order.
I think you're right, though. We got to try things.
Yeah.
I can see a world where there is the token-driven healthcare ecosystem. So the folks that won the hackathon, they're talking about selling your health information to people for research. Why not sell your information to a pharmaceutical company to advertise their drugs? And there are all sorts of other issues but if they're paying you in a currency, a unique currency, why can't you use that to pay your doctor? Why can't the doctor use that to pay their suppliers? And it sort of gets to more of a cashless system.
Yeah. And I think the other thing is kind of this, there's got to be a social contract around that data that says that if you're able to pool and really case match at a really complex manner so that you could look at comparative effectiveness and everything else, and I think part of it could be that people don't get paid. It's part of the ante, if you will, to participate in that environment. I think it drives up to different kind of ethical issues about who's monetizing what, and who opts in or out. So I think we need kind of a rule system that goes along with that, because I think us in this room, we could figure out all these different things probably if we thought hard enough about it. To the average person who's a teacher or a working in a shop or something, them opting in and out and how their health data gets monetized. I mean, we got to be pragmatic about the type of decisions we're asking people to make.
Sure. Or you could see a world even where, to your point earlier on the ambient churn perspective, a payer gets compensated for making the right decisions, even though they're more costly today on a given patient. They know that patient potentially is going to be churning out of their network in 1, 2, 3 years, but they get some kind of coin because they did it the right way,
right,
that they can then use later on, and everybody agrees, and that might facilitate some kind of different way of thinking about continuity of a patient that we've never had before.
But going back to the whole revenue cycle piece, that's a really good example, because that could be part of a smart contract, right, that drives better care that is going to be reimbursed, despite potentially a higher cost.
Exactly. You're not making short-term decisions from a payer perspective. Everybody's incentivized to do the right thing there.
You guys want to open it up for questions?
Questions are good.
Right here in the middle, the guy that voted on clinical. Is there a microphone somewhere? Bryce?
Yes.
Yeah. Yeah, I think, did you guys, I think it was the question of whether fire and that kind of, the API, what role does that play in accelerating this? Are
Building it's building a golden record, right?
Yeah. I think I'll take the beginning of it, but I think these guys are probably more qualified than me. I think, having APIs would define frames and structure and definition and simple 834 call. I mean, there's certain things that, everybody will benefit from. It does open it up. It doesn't address, I think, some of the issues that blockchain does address, which is who gets to control, how do you have an audit trail, right, that's date span or time sequenced, because that fire service is it's peer-to-peer between two transactions, and a lot of the stuff we're talking about is going across multiple different entities with multiple different systems. So something that strings all that together, I think, is beyond just the fire service part of it.
I mean, the promise of blockchain is that it's leapfrogging something like fire, and it's incentivizing everybody to be good actors in the system. And
Right.
I think that,
They're mutually inclusive, though. I don't think they compete. They have different roles, I think.
I think fire has a role in terms of data accumulation. So if you want to start using those standardized transactions to bring data to a central place, that's where I think they can play a role.
Mm-hmm.
Well, and I think, the enablement of those APIs to make it accessible for it to integrate with a blockchain solution or a blockchain-powered solution helps as well. But there's still going to be problems, if we're not representing data in the right way within FHIR, within those tags. I mean, we still have standardization issues that I believe FHIR won't address all of those. Neither will blockchain. It's going to take, incentives and other things to really get people aligned around how we need to share information.
Only in healthcare do you have non-standard standardized transactions.
Yeah.
Well said.
Just
Another question over here.
Quick question to clarify. Up where I'm from in Kentucky, a lot of the providers, the acute care, use a third-party source like a Conifer. Where do they play the role going forward? Because you've got giant corporations that are making a lot of money by handling that service for the provider to integrate in, because I think it goes back to what Ray said earlier. There's so many people involved touching these things. Does that go away and the provider becomes more pure with blockchain, or it's a cost savings? Or because to me that seems like that would be a roadblock, because those people obviously don't want their revenue to go away for the service they provide.
I can start that because I think we are a third-party outsourced vendor for providers. And like I said, I think we will be reactive. If blockchain starts being the way that you want to get paid, like we will adapt and make sure that the providers get paid that way. The guys who we represent, or gals, or provider organizations are usually very big. So they got to worry about a lot of other things, accrual accounting, they got to worry about analytics, referral patterns, all these other things that are tied into their reimbursement models. And we're going to need, that's just going to heighten the value that people are going to perceive for those types of layers of services. So it'll change differently than just the pure, I file your claim, it gets adjudicated and reimbursed. At least that's what I think.
Anybody else want to take a shot at that before we go to the next question?
Well, I think too, like there's, and just to, I guess, jump off what you're saying. So there's different capabilities that you're offering, and then blockchain could potentially allow for frictionless communication between the different payers and providers. And so underneath of that, that's blockchain, but then on top of that, there's all these capabilities that are now counted on by providers that they would need.
Right. So I think we could take your question about who gets disintermediated or whose job changes, and I think one of the many things that is potential is that once this kind of adoption begins, that you lower the threshold of new entrants coming in and competing. And so I think you're right. There's going to be resistance from the status quo because their revenue model is going to change, or they're going to have to find a different way to justify their value for what they're charging people. So I think this actually makes it easier for new entrants to compete in that space. I think there's a bunch of people that are betting their business on it, that they're going to be creative destruction or whatever you call it. At the same time, you need these big guys who have the money to kind of explore and invest in it. And I think that they realize that if they don't change, and somebody else breaks through, that their business is at risk anyhow. So there's some inevitability to it. And we've seen that in a host of other businesses, you know. I took a taxi cab yesterday for the first time in probably a year and a half. And I'll tell you, it was still a pretty crappy experience. It was unbelievable. You know, the guy was rude. He didn't put his bag in. And this is after his business is just getting attacked by Uber. And they still suck. You know, so you know, I think things will change, you know. But, you know, I got one quick story on this one, just because it's funny. So I don't know, the company knows, do people know the company Moen, the faucet company?
Yeah.
So it's a guy from Cleveland, outside of Cleveland was Moen, and he developed it where it's one faucet that controls hot and cold and how hard the water comes out. It took him 17 years from that invention for anybody to buy it. You know why? Because the hot's on the left and the cold's on the right. 17 years, right? So, you know, even if something's a superior device, it doesn't mean there's going to be adoption when we think it should happen. So hopefully we're not mowing here.
No, well said. I saw an article on LinkedIn on one of your pop-ups the other day from a name brand revenue cycle company. I mean, huge organization, multi-billion-dollar organization, not represented here. And I was like, oh, well, this will be an interesting article. And I read through it. It was stuff from the 90s about KPIs and organizing your denials and understanding your reimbursement codes. I was sitting there scratching my head thinking someone published this in HFMA probably 20 years ago and just dusted it off and reissued it. But that's what we're facing, hot, cold.
Yep.
Or for you guys, hot, cold.
Right.
Another question?
Yeah, this is broader. I was at last year's Distributed Health Conference, and it seems there's real traction and concreteness, you know, increasingly in this year's, et cetera. My question is, I'm just wondering, and I know at least one company up there has got international interest, is there anything to be learned from blockchain applications outside the U.S.? And Estonia is one that always comes up, but there are others, hearing of things in the Caribbean and what have you. I know there are faculty members here and in Atlanta and elsewhere working on things like this. Are you learning anything from beyond the usual suspects, I guess?
I mean, I absolutely think there are things to be learned. I mean, Estonia is doing a lot with immutability and ensuring that whatever's been entered hasn't changed. And so using that, the UAE is doing, I think, some work too. I don't know if Estonia is really the only one that's actually done something, you know, that's reached a maturity level where you can start talking about it. I think it's the UAE's trying to get into that space, and then the Gates Foundation invested in Factum, and they're doing some work in Africa. And so I think as those mature, there'll be other things to learn. But I definitely think that there's learning there.
My biggest takeaway from that is, or the learning is making sure that you are fostering a welcoming, open environment to innovation around blockchain, and like conferences like this in Nashville and everybody in healthcare trying to say, okay, how are we going to figure this out? That's awesome. Like, that's how we get those type of innovations into our ecosystem. Like, I think Switzerland has the blockchain valley or the Bitcoin valley or whatever. I mean, like those kind of things, that's how you get the innovation into your space. And I think that's the biggest takeaway that I've learned from those types of things.
Right.
I was just going to say the other probably really important takeaway there is committed leadership. Right, it didn't start out with a bunch of people in the country. The leaders of the country decided, hey, this is the right technology, and it's going to have to be like that in healthcare too. The leadership is going to have to take a stand and say, hey, this is a direction we're going to follow.
Yeah, I think it seems like it'll be more likely to be imposed on healthcare because they're solving a problem in a different industry like Equifax, where it's so massively compromising everybody, including me. I mean, I looked it up. I was so frosted that my stuff got hacked. I mean, probably most people here, and you know, now I'm paying American Express $10 a month to kind of monitor my accounts. You know, everybody's figuring that out, and so I could see where other countries, other areas are going to impose data security, for example, and say this is going to be the standard, and then people are going to say that's across all industries, not just retail or banking, but also healthcare, and that'll solve a problem for us on the PHI side, right?
Do you think HIPAA gets modified because of a combination of what blockchain could be and, say, an Equifax issue?
Yeah, I think when you really understand the scale of that compromise, I mean, it's just, you really can't get your head around it because it's so substantial, and so I could see where people are going to say, how do you inoculate yourself from that kind of risk? If it could happen to Equifax, and some other countries would be willing to take a more active, centralized role in solving that than maybe the U.S. would, and we're going to see that was a good decision. Why don't we emulate that? Why don't we follow that lead? Sure. It doesn't have to be invented in the U.S.
I mean, think how much money a business like ours, we do 70 million plus transactions a year. We worry about security all the time. We have to continue to invest in that kind of stuff. If I knew that there was some kind of healthcare standard in blockchain and it was like, I didn't have to worry that much that it was secure, like it was good to go, then how much could I save from not only sleep at night, but just the resource perspective?
Yeah, every time we sign a BAA, and it's, data use and PHI and limited liability, we negotiate the same terms every time. I mean, if there was a universal way of addressing that type of risk, then that risk premium we're all paying, is kind of equalized.
Be a lot of mad insurers.
So is that another use case as a universal business associate agreement?
Yeah, why not?
Make life easier.
Yeah.
Another question over here, real quick. Yeah. This is more of an operational question. Ray, you touched upon in the morning when you said the existing system was built on the financial rails that was really old. Now, going forward, what does the panel envision? Is it one major player driving this, or many small networks forming? Meaning, the 1,000 ACOs, if they really can get to a point of full risk, they can potentially do many things. There could be new entrants into the marketplace. They decide to find out how best to drive outcomes. In that case, do you guys envision many such networks coming up? Or is it going to be a subset of, like, for example, in 2000, when the exchanges came up, there were a lot of exchanges. More than half of them closed out within 1 year. And then came a consolidation period, and finally a few survived. What do you expect in this situation?
Who wants to take it?
I can hear.
I'll go back to what I said earlier. I think it's going to come back to, I think, a patient-centered sort of a golden record that the patient can control. We saw the code that was flashed up earlier. You take a picture with your phone, the patient shares that with whomever they decide it needs to be shared with. I think that's one way you start to consolidate all that data.
Mm-hmm.
I think we touched. We talked about. I think the question was like, would small networks of blockchains happen? There's very few. I think small networks that can actually handle from every single specialty procedure possible that aren't actually really big systems, and that would take a really large lift. So I think about that in the perspective of small networks, like how practical, how many of those are there actually that could handle that kind of thing?
So does someone like the federal government drive it with Medicare? I hate to put anything trust in the federal government.
Uh-huh.
I'm just digging that hole.
No, but look, I think as much as people bash Medicare, they create convention. They did DRGs, they did ASCs, they did APGs. We could go down the road of it, and everybody's going, "Oh my God, that's the best thing." So I think there's a role for the 800-pound gorilla. As long as it kind of it opens up the market. And I think most of the time when they go do stuff, it does open up the market. There's a ton of innovation that happens every time around that. So I'm okay with them stepping forward. I think it clears, at least you got somebody kind of, creating a catalyst that the private sector has a hard time getting going on. So I'd be supportive of a couple of big moves by the government to drive adoption. But I think it's, the question is in what area. They could do the master provider stuff. The government needs the same provider data, same, it could be that it's on the security side. I think another big hack that's equivalent to what happened with Equifax in a different sector, tapping into the PBM business, screwing that up, that could be, that could, that's scary stuff, So, I think it's, the application is going to be imminent. It's just where it happens first. We don't know.
Any other questions? And Bryce, were we done at 3:30? Is that the?
Yeah.
Okay.
So, in the revenue cycle industry, what would you say are the main three things that we should focus on? Because I'm, in the end-to-end revenue cycle management, claims, contracts, coding, billing. What should we look at as coming in with the blockchain? I hear you said bring in data the data of the EHR to a centralized place, smart contracts, real-time funds transactions. I'm just trying to, get a clear picture on what should we be focusing on with the blockchain in the revenue cycle.
And Ray has a hard stop, so.
Yeah, apologize. Thank you.
I'll take the first part of it, but like I would get very tactical. I think Jim, you mentioned it at the beginning, but like adjudicating authentication and having a record for that, like if you could solve that one little problem, you'd actually save a lot of money in the system and a lot of heartache. Like so, I would focus like a laser on something that's like a pain point for everybody that actually everyone could like agree upon that's actually helpful. I don't know.
Yeah, I would say contracting. Using smart contracts to drive that reimbursement. And I think the medical record piece is everybody seems to struggle with that. We work with a lot of payers and providers, and you hear time and again, there's a medical record requested and nobody can find it. So please send it again. And then 3 or 4 times. So that I think, just probably those 3 areas for me.
Yeah, I think, just eligibility, and understanding, does this patient have coverage, right? And then building on top of that to understand what their accumulations are and driving that conversation so that they can understand this is what the cost shares are and how that's breaking down. I think that's kind of the first conversation to focus on and to equip both the patient experience and the provider experience and enable those. So it has the potential to. So, a lot of this, we're saying, hey, where are we with this? Where are we starting? Everybody's saying, hey, it's emerging, we're learning. It has the potential to. So the question is kind of, how are we going to get to that? Where are we? Are we there yet? And how, right? And so it could actually store accumulations, right? Or it could point to a place where you could go get the accumulator so you can know in real time, this is where you are toward your deductible. And then from that, understand this is the relationship that's between the patient and the health plan, as well as potentially that relationship between the provider and the health plan, so that you know kind of exactly what contractual relationships exist there for that service, and then be able to say, okay, this is, if we have it at this point in time, this is what this would cost.
Mm-hmm. Yeah. I think we differ a little bit. I think that real-time formularies actually, anyone who's filed a claim and filed it on behalf of different providers for the same surgery knows that nothing is really real-time, and you gotta, filing the anesthesia bill versus the actual surgery bill, what hits first and when, and there's a lot of stuff that you have to navigate on that. So real-time on that part, I think is makes sense at 40,000 feet. Now in the blocking and tackling, it's really tough. But I think contract variance is actually one where you could actually get to, you have a contract with a payer, you get paid X for Y procedure. We know that happened or it didn't happen. And you could automate all of that on a blockchain versus, having a ton of people scrubbing and making sure, or a bot go through. I mean, and the hard part is when you start changing those contracts every year, which you could pretty easily do, I imagine, on a blockchain, that adjudication process. But
any other questions? All right.
Thank you.